Okay.
Sarah, can you hear me okay now?
A little better. Yes. A little better. Light, but
Okay, I'll try and speak up. I don't know if it's my microphone or whatnot. Okay, so thank you so much for joining us. I'm excited to talk to all your school nurses again about sickle cell disease and school considerations because, as you probably are noticing, you're seeing more and more of it in Maine. Next slide. So today, I just want to go over who we are at the Maine Children's Cancer Program. We're not just cancer, like the name suggests, we're the hematology program as well. We're going to talk about the basics of sickle cell disease, sickle cell complications and school considerations, treatments for sickle cell disease, and resources. Slide. So we're the Maine Children's Cancer Program, as I said, in Scarborough. We are part of Barbara Bush Hospital, and this is our sickle cell team. Go ahead. Yep. So this is Dr. Z. We have two physicians that primary our sickle cell patients. All of our doctors are hematologists as well, but these are the two docs, Dr. Z and Dr. Weiss, who primary the patients. And then our nursing staff. So any nurse in the clinic can take care of our sickle cell patients. But again, we have primary teams and primary nurses for our sickle cell group. This is Pam, and then, of course, myself and Amanda McGeechee. And then we have two great social workers. The social work team is a really important part of the sickle cell team and sickle cell clinic, just with the many needs that these families have. So we have Emily and Dee Dee. And then we also are very lucky to have a child life specialist that works with us as well, Kelly. So she has been with our team now, I believe, about 2 years, and she helps within the clinic with blood draws, distraction. She can work with the families and kids and explain different procedures and just some medical play. Another big part is pill swallowing that she can help patients with as they get to the age where pills are appropriate. She has some special tricks. And then, next slide, Amanda. So, where and when do we see our patients? So, our clinics in Scarborough, as I said, we at the clinic we do visits usually about every 3 months, and these are our routine preventative care check-ins with the families. We're doing labs, we're doing an exam and a visit with the doctor. Social work visits the family, child life. We do patient education. We're checking in on medications to make sure that they're taking their medications. What do we need for refills? And then we also sometimes have a music therapist that joins. So though that we see the patients in the clinic generally when they're well, we're teaching them how to manage their chronic disease. Of course, these patients need sick visits as well. Generally, when patients are sick, they're seen in the emergency room. There's sort of a number of factors that go into that. If we have clinic space and nursing availability, sometimes on occasion, if a family does have transportation, we can see them in clinic. But for the most part, we're directing them to the emergency room just because the acuity of these visits require usually one-to-one nursing when a child is visiting us for pain or fever. And for the most part, when a patient is seen in the emergency room, they're usually sick enough that they're going to need to be admitted to the hospital. So just logistically, it makes sense for them to go right over to Maine Med. Um, or if they live in, say, Lewiston, we're going to direct them to St. Mary's or Central Maine. We would call ahead, our nursing team would call ahead to the emergency room and direct the team what to do with them. Okay, next slide. So our numbers. So as you probably have noticed in the schools, sickle cell is definitely here in Maine and growing. And Amanda, you can just hit the. So we started out. I started taking care of this population when I first came to Maine Children's Cancer Program, and that was around 2013. We had about 15, 14 patients ish. Now we have about 86 patients total. In the last year, we've had 10 new patients. And I will even say that in the last 2 months, we've had at least three new babies with sickle cell disease. So um, clearly, the population is growing. Most of these families, just to go over some barriers, most of these families are new Mainers. Their language, you can go ahead and hit the space bar. So they generally don't speak English as their first language. We see a lot of Portuguese, French, and Lingala. They have transportation needs. So that's another barrier, getting to clinic. And if they do get to clinic, getting to clinic on time, getting to a sick visit if they're sick, getting to the emergency room, how are we going to get them there? And then also just the perception of sickle cell disease becomes a barrier to care as well. A lot of these families didn't know that their child had sickle cell disease before they came to the country. And what happens is when they have like a new entry screen and they come up for sickle cell disease, then they're referred to us. And most of these families, if they didn't know their child had sickle cell disease, it's because their child has been well. And their impression of sickle cell disease is people who are very sick um, or have maybe even they've experienced death um, with a child that had sickle cell disease. So that is a real challenge to explain to families that yes, their child has sickle cell disease and they can still live well, and we can take care of them, and we can teach them how their child can have a healthy lifestyle, and we can treat the complication. And as we've had growth in our sickle cell population, we've been working over the last few years to really account for that. And some of the things that we've done is we have care algorithms. So when a patient goes into the emergency room, there is an exact algorithm of how their pain should be treated. Um, it just makes it easier for all the providers to have something to follow and to make sure these patients are getting quick care. We've also flagged in our electronic medical record that these patients have a high risk diagnosis. We recently did a project. Another barrier to care along with transportation is getting to some of these appointments. So we run an ultrasound yearly on our patients, and we were able to move the location to the same building that we're in so that we can coordinate this with their visit to clinic. We were finding that we were having a lot of no-shows, and this is a really important test. So we were having a lot of no-shows, and something needed to change to be able to get the patients this test. So it's now coordinated on the same day as their clinic visit, and we're having much more success with it. We've been working on community outreach because clearly the community is a huge part of our sickle cell team. These patients have a chronic disease and they are going to school. They're out there in the community, and we need the primary care providers to know how to work with them. We need school nurses to know how to work with them so that they can live their life with sickle cell disease. We've also done a sickle cell care card, which each family has one, and we tell them to keep it in their wallet so that then when they go to an emergency room or an urgent care facility, they can hand it to the providers, and it will tell them that they have sickle cell disease and then to contact us to discuss their care. Just recently, we have connected with community health workers. So they work out of the Community Care Informed Initiative Clinic. And this has just been a wonderful thing for our patients and for us as providers. What we do is we do a referral to this group, and they will connect with the families. They can come to our clinic, and generally the people that are in this role are Portuguese or French or Lingala speaking, and they have experience with that culture. So they're able to act as like a medical liaison between us and the patients when we're having a little bit of a hard time maybe reaching the patients or explaining medication or treatment. So that's been a huge thing for us. And then currently, I'm working on some new teaching materials for patients, translating in their language, which is a huge need. Okay, next slide. So, just to get into sickle cell disease and what it is, it's an inherited blood condition that essentially the patients do not produce the correct hemoglobin. They produce a hemoglobin that is sickle shaped and therefore clogs up the vessels, causing issues. And this little video, Amanda, you can hit play there. It just shows a nice visual. Is the volume on? Maybe the volume's not on. All right, well, can't hear it. I thought you were going to be able to hear it, but here's just kind of the visual of what happens in. Um,
Do you want me to keep playing it, Shannon?
sure, yeah, that'd be great. Um, it's just a nice visual of those sickles shaped cells clumped together, and then the normal hemoglobin is not getting around. So those clumps can cause pain, and then also you think about it, that then oxygen is not getting to all the places in the body the way it should, therefore causing some silent damage. It can result in fatigue, pain, silent damage, infections, and stroke. Just a few to name. Okay, that's good. You can end it. You can go to the next slide. So who's getting sickle cell disease? So it's the most common genetic disease in the U.S., and it generally affects Black or African Americans. But of course, there are some other heritages that are affected as well. Next slide. And then here's the genetics of it. So it takes two parents that have sickle cell trait to have a child with sickle cell disease. And this is why I think a lot of families are so shocked, because a lot of parents don't realize that they have sickle cell trait because there's no symptoms or signs. They feel healthy, they're great, and then suddenly they have a baby that has sickle cell disease. So I think it's a big shock for families if they had no idea. They could have gone on, for years and there was no actual sickle cell disease in their family. Next slide. And then just talk a little bit about the newborn screen. So this is the major way that our patients get to us is the newborn screen. It's a universal screening that's done in all 50 states and identifies patients who have sickle cell trait and sickle cell disease. So when a sickle cell screen comes back on a newborn, we get that from the state, and then we contact the primary care provider and we tell them that they need to start the baby on penicillin. It's great because it's early intervention. All babies up until the age of 5 are on penicillin twice a day, prophylaxically to prevent infection. And then they do a referral to us and we establish care. We also often hear about patients through when they're new Mainers. They're referred by their PCP after a positive hemoglobin S screen. Or there's also patients that just show up to the emergency room in crisis and it's determined that they have sickle cell based on their labs, or the family already knew and tells the providers there, and then they're referred to us. And now with the newborn screen, too, we often see patients in consults that have sickle cell trait. So it's just a one-time visit, and really there's no health effects necessarily with sickle cell trait, but what the visit is about is counseling the family that the child has sickle cell trait, and it would be important for them to know later on when they decide to have children. So it'll just be interesting to see now that there's this newborn screen in place as the future comes along. Are there still going to be as many babies that have sickle cell disease if people are aware that they do have sickle cell trait? So now I'm going to get into sickle cell complications. And The main ones I think that you're probably encountering at school is pain, which is the vaso-occlusive crisis, fever. I would say those are probably your biggest ones. And other ones that I just want to touch upon are acute chest syndrome, stroke, aplastic crisis, priapism, and then just to briefly mention about ophtho issues. And sickle cell, the basics of it are that these cells clog up the vessels and cause pain and other issues. But when you think about it, these patients are chronically anemic, so their body is not fully getting the oxygen it needs everywhere. So, and they really just have little reserve. So, essentially, sickle cell disease can affect any area of your body. All right, next slide. So, vaso-occlusive crisis, more commonly known, as a pain crisis, is caused by the sickle cells becoming trapped, interfering with normal blood flow. It's important to know that, pain can occur anywhere. We often see it in the extremities or back. With toddlers and babies, you'll see swelling of the hands and feet often, and that's called dactylitis. And that can be really painful for them. And I think just, as nurses, we're all trained that pain is what the patient reports. And I just think that that's really important to hone in on with sickle cell disease because there really is no reliable science to test the presence or absence of vaso-occlusive crisis. And it's based on self-reporting. And it doesn't necessarily show huge changes in vitals. So just, keeping that in mind that these patients really do experience horrendous pain and usually have a pretty tough threshold as well. So to manage VOC, fluids, rest, warmth, you could do distraction. The child life is wonderful in these situations too. You never want to use ice, even if there's a sports injury. Ice will cause more pain, so you always want to go for warmth. And then oral pain medications, so NSAIDs, opioids. If there's no relief after oxycodone, they may need to be seen in the emergency room for evaluation. The goal is to detect this early and intervene early because once pain starts, if it's not treated, it's only going to escalate. So just thinking about the outpatient pain management plan. So ibuprofen is your first line for mild pain. So our recommendation is to start with that. And then the next step would be to add an oxycodone. Or if the student or patient is presenting in what seems like pretty severe pain, you can start with both ibuprofen and oxycodone right away. And then also, I also just like to say that even if you're giving oxycodone, you still want to give ibuprofen. Ibuprofen is a really good medication for the management of sickle cell disease pain because of its anti-inflammatory properties. So always include that with the oxycodone as well. And, I think a lot of the families are a little bit hesitant to use oxycodone. And, just to mention, there's not a perfect solution for the use or not of oxycodone. And, I think that there's a lot of fears surrounding it and a lot of stigma with addiction and things like that. But I would just say that, we do monitor their use, their refills, and then we also have a PAP team that we collaborate with, and just thinking about other ways to control their pain if we're worried about increased use of oxycodone. So within the school, real big is prevention, avoid cold. And I think that that is always a huge question for school nurses is, do we let these kids go play outside? And the answer is yes. But we want to make sure that they're properly bundled. We use a guideline of 20 as a feels like temperature. They shouldn't be outside if it's less than 20 as a feels like temperature. And they should also be properly bundled. And if for some reason they don't seem to have the right gear to go outside, certainly you could let us know and we can see what we can do to help with that, because we really strongly also feel like it's important for these patients to be able to get their outdoor time and to be with friends. And certainly, if they do need to stay inside for indoor recess, um, if a friend could stay in with them or there's an alternative activity, it would be great. Always encouraging hydration. Hydration is a huge part of pain prevention. And then if a patient has a strong history of pain and VOC, then we can do a school pain plan. And then on the next slide, I copied from a letter that I had sent to one of the schools for pain, a pain plan. And certainly, I think it's probably just up to your school district, the comfort level of giving oxycodone at school. But we're really grateful at this particular school that they are able to give oxy to this patient who has frequent pain, and is able to stay at school with oxycodone on board. If you want to just click it, I can go over it. So the basics are of with the pain plan, is just outlining their history, and then we can give clear guidelines with this patient. And this is kind of individualized for this patient, who we know definitely has frequent pain crisis and escalates on the pain crisis very quickly. So, it's a kind of a low threshold. If he has a pain level of 1 to 2, we should start by ibuprofen. But if he's rating pain that's higher than 2, we need to go right to adding in the oxycodone. And certainly, you are going to know these patients and these students, and you'll know what their baseline is and can use your nursing judgment. And then, the family should definitely be involved in kind of taking ownership of knowing that they need to get the child if the child's in pain. And if for some reason they can't get to the school quickly, we suggest that you call an ambulance for transport. So the next complication to cover is infection in sickle cell disease. So patients with sickle cell disease are at increased risk of serious infection, mainly due to the fact that they don't have a functioning spleen. Their spleen is present, but because the blood flow, the spleen gets clogged up, it doesn't work properly like anyone without sickle cell disease. So they become at high risk for particularly pneumococcal infections. So we try and protect these patients by doing the penicillin that I had mentioned previously until the age of 5. And studies show that after the age of 5, their risk level goes down. And then also vaccines are very important for these patients. So we're in close touch with the primary care providers to make sure that they're getting the required vaccines. We're also treating fever in a sickle cell patient as an emergency, and covering them with IV antibiotics just in case it could be a pneumococcal infection. We don't need to wait to find out that it is pneumococcal. We are going right ahead and treating them with IV antibiotics. Next slide. So a fever is defined as a temperature greater than 101 degrees for our sickle cell patients, or 38.5. We consider it an emergency, and this is a case that we have a algorithm for the emergency room that they need to strictly follow to treat these patients. A big teaching point for families is to not give ibuprofen when they identify that their child has a fever. I think that so many families see that fever number and just want to give them ibuprofen and think, oh, we took care of it, it's treated, we're done. Not the case. We worry so much that a patient is going to get ibuprofen to mask the fever, and then they get horribly sick. So we really mention that in every visit with them. So at school, you want to contact the family immediately, and then you don't want to give ibuprofen or Tylenol in the school setting when you find a fever. And again, if the family cannot pick them up, don't wait. You want to get them to the emergency room in a timely manner. Acute chest syndrome is essentially a pneumonia in a patient with sickle cell disease. These patients just can't compensate the same way because of the decreased oxygen delivery. So, it really is just a pneumonia with a fancy name, but just knowing that it can be very dangerous in our sickle cell patients. So you're looking for chest pain, fever, cough, any of those respiratory symptoms. At school, you would want them evaluated if they're having anything more than a mild cough. And certainly if they're having fever, acute chest could definitely be the culprit. And with acute chest syndrome, they're going to need evaluation. Likely, they're going to be admitted to the hospital if they're identified to have acute chest syndrome for IV antibiotics. Um, when they go to the emergency room, they're going to, of course, do a chest X-ray if the patient is having any respiratory symptoms. Stroke. Individuals with sickle cell disease are at high risk for stroke. I mentioned we do a yearly surveillance test, the transcranial Doppler ultrasound, to evaluate for the risk of stroke. And this is a really non-invasive, simple test that the picture just shows. It's just a little wand that goes up by the forehead and gives a measurement. And if their risk comes back as high, there's certain interventions we can do. We might choose to increase their hydroxyurea, or we might start chronic blood transfusion, which is a treatment for stroke and for the prevention of stroke. So recognizing stroke, you want to think about the same things that you would in an adult, some of those red flag neurotype symptoms. And if you notice any of these things at school, certainly notify the family. And if you have, high concerns, they go to the emergency room. And just thinking about school considerations with stroke, you want to think about that they might have more absences because they would have to get the monthly blood transfusions. And unfortunately, right now, our clinic hours only go till 5. So they would be missing probably one day a month of school if they needed to be treated with the chronic transfusion. And then also, just the next one, think about the neurocog defects. If a patient has stroke, definitely, absolutely, they should be thinking about neuropsych testing, but also any patient with sickle cell disease, we should probably be thinking about neurocog testing. There are silent strokes or mini infarcts that can happen that we may not even know about. Chronic anemia. So as the name suggests, sickle cell anemia, these patients generally live at a much lower baseline hemoglobin. Some of our patients run a hemoglobin of 6 or 7, which is amazing because the normal value is around 12 to 15. And just to kind of give you an idea, in our oncology population, if a patient had a hemoglobin of 6, they would get a transfusion. But these patients, that is their baseline, and they may live at that level, and they're used to that. The lifespan of a sickle cell is about 20 days or less, so the turnover is quick. And these patients really just don't have the reserve. So that's where we worry about these patients, because they can decline really quickly because they don't have a backup reserve. If they live at a hemoglobin of 6 and suddenly they're ill and they're not making the hemoglobin quite as quick as a healthy child, their hemoglobin could drop to 4 or 5, which could be quite dangerous for them. Click again, spacebar. And again, this is their baseline. So we're always talking about their baseline hemoglobin. We want to know where they live, because if we know a patient's baseline is at 7, when we get the labs, we don't need to panic that their hemoglobin is 7. But if their baseline is, say, 9, we get a hemoglobin of 7, then something's going on. So they may tire more easily. They have less reserve during time of illness. They should, at school, you think about in PE class, we want them to participate, but they also may need to take more breaks than other children. Okay, next. Aplastic crisis concerns. So essentially, this really, again, is just the fact that they don't have the reserve. So splenic sequestration means that it's a crisis where blood goes into the spleen, it gets trapped, and it doesn't come out. So it causes anemia and thrombocytopenia and can cause rapid drops and be really dangerous. Things that you would see are large spleen, abdominal pain. You want to check out their color if you're looking at their nail beds, their gums, their lips, they're looking pale. Something is off from their baseline. Infection, so parvovirus can be really dangerous because it pauses the red cell production. And with these patients that have sickle cell disease, with their cells only lasting about 20 days, they need to be constantly producing to keep up to their baseline. If there's a pause in production, then they are going to drop dramatically. School considerations, just watch for those symptoms of anemia, fatigue, extreme fatigue, shortness of breath. We had one patient who had parvovirus, and the indicator to me was the mom said at school she had a really hard time walking up the stairs, and that was different for her. So it's just kind of knowing their baseline and those small changes could really mean something. Increased jaundice, patients with sickle cell disease, you are going to notice that their eyes are often yellow because of the cell turnover and the breakdown. But if it's a new symptom and that's not their baseline, that's definitely something to be looking at. Okay. Priapism is a sustained painful erection, unwanted. We treat it like a pain crisis, and this definitely happens. In teenage boys, we do hear about it from them. So you want to do supportive care, which is just increasing fluids. They can urinate, that sometimes helps. Pain medications, bath, movement. So it's just important for everyone to be aware that this definitely is related to sickle cell disease, just to prevent embarrassment for these students. If they were to come to the office with this issue, that's what it's about. If it lasts more than 2 hours, they should have evaluation. And then as far as vision changes, related to sickle cell disease, patients can get a retinopathy, and they see ophtho yearly as a preventative exam. There aren't necessarily any signs to this, but I think it's just good to be aware that they are probably going to miss one day of school for this ophtho visit yearly, and it's a long exam. It's a dilated eye exam that takes 2 hours. And then certainly, reporting any changes in vision if there is any symptoms that are seen. Okay. Just want to touch on dehydration and kidney disease. So certainly their patients are at risk for kidney damage. They may have increased urination, bedwetting, increased thirst, dehydration. So it's really important to allow them unlimited access to the bathroom, and also with students needing more hydration with sickle cell disease, just please allow them to have their water bottle at their desk. I think that's probably a standard for most students now to be allowed to have that. And then, sorry, I just had one more point to mention on that one. If these patients have vomiting and diarrhea, they need to be monitored closely for dehydration, a little bit more than someone without sickle cell disease. If they're vomiting and diarrhea, we want to definitely know what their urine output and their intake is, because again, they could then go into crisis if they're not getting the proper hydration. Okay. All right. So now I'm just going to talk a little bit about medications and treatment of sickle cell disease. So the medications that these patients are on generally are hydroxyurea, folic acid, and then they have their as needed pain medication, ibuprofen, oxycodone, and then if they're 5 or under, we keep them on the penicillin. So all of our patients should have ibuprofen at home. Oxycodone, we generally prescribe to patients to have on hand that have had a history of needing it at home in the past. We used to have everyone have Oxy at home, but then it got to the place where patients weren't really needing it and it was expiring and we were doing a lot of prescriptions. So it seems to work well. And then we also know that they're calling us when they're having pain so we can help assess. Okay, next. So hydroxyurea, it's the most effective drug treatment for sickle cell disease, and its use has really increased over the years. Now it's recommended to start in infants. It is recommended, not necessarily required. So it's a little bit tricky. We want all of our patients on it. We really recommend it and go over it at just about every visit until hopefully the families agree to do it. But it is, essentially still a choice for families. And sometimes it takes a little bit of time for the families to see that that the patient is having some effects from sickle cell disease. If they're having more pain, more hospital admits, then the families might tend to get on board. I think again in this population, it's often hard for families to give a medication to their child who appears healthy and well. So sometimes, unfortunately, it takes them to see some illness first. So what hydroxyurea does, it's a daily medication. It's available in pills and also a compounded liquid. And it increases the fetal hemoglobin, which then helps to decrease the amount of the sickle shaped cells that patients have, therefore causing less complications. Okay, next. The biggest issue with hydroxyurea is compliance. So the issue with compliance is sometimes these patients don't feel sick. So why do they need to take their medication? And there's no real reason for them to remember to take it. Also, we have noticed that a bit in this patient population, these families, some of these maybe school age to teens, they're sort of on their own taking their medication. And that's something I don't fully understand, but we have definitely noticed that the parents sort of rely on the kids to take the medication. So we really try and give ownership to the patient. When I do my med rec with families, I am asking the patient, even if they're 8, 9, 10 years old, I'm asking them if they're taking their medication and how many days a week do they think they get it in and how many pills. And hydroxyurea comes in all these different colors based on the strength. So I'll often ask them to what color their medication is, just so that they're aware and they're noticing what their medication looks like. So this has come up, I would say, in the last year or two. We've had a couple patients where we've asked if hydroxyurea could be given at school just to help with the compliance. And it doesn't always need to happen, but just to mention it in case we do approach you about it, and I know there's certainly different rules around administering at school, and we can discuss as needed. But again, it doesn't give immediate relief and it takes some time to work. So sometimes if we can get a patient in the habit of taking it and take ownership of taking it, then they'll start to take it at home. And honestly, I think 5 days a week of hydroxyurea, and if they don't take it at home on the weekends, is so much better than none. So we're just hoping that we can get patients to be a little bit more compliant. And this was just an idea that we have to take charge of it. Okay, next. So, just for administration tips, just to know handling, we do have caregivers wear gloves and hand washing. We don't necessarily have the families at home wear gloves. We just suggest hand washing, but if it was given at the school or in our clinic, we would use gloves. We encourage, as I was mentioning, to have the patient or student you can give them the bottle and they can take it on their own so that they're used to doing it themselves. We don't open the capsules. They're in capsules for a reason, and we don't want them opened and the powder to be spread. But if a patient can't swallow pills, we have options of having Child Life work with that patient, and we also can get liquid. Um, the liquid can only comes from Maine Medical Pharmacy, but that's definitely an option. It's really well tolerated. The few side effects are darkening of fingernails and then some mild GI upset. But honestly, I really don't have any patients complain of GI upset. It's just listed as one of the side effects. So if that comes up, we can give it a snack around mealtime. Stored at room temperature, and if it's liquid, it needs to be in the refrigerator. And certainly, we would do a school letter with all the information needed if it was going to be administered at school. So the dosing, just a quick note that the dosing does fluctuate a bit. It has a start place and a max place, but we're also looking at their labs because one of the actions also is that it increases the fetal hemoglobin, but also decreases platelets and white blood cells because the platelets and white blood cells can be kind of sticky and get clogged up as well with those sickle cells. So it's helping by decreasing that, but we don't want it to be too decreased. So it's kind of a sweet spot, and everyone tolerates it a little bit different. So every 3 months when we're seeing patients, we're looking at their labs and adjusting their dosing. Next. And just a quick mention, there are some new things on the rise for sickle cell disease treatment. You may have heard there are some curative therapies. Stem cell transplant is out there and an option. Definitely has risks and really is reserved for patients that have a really good match, which is generally a sibling, and a patient that has been experiencing severe complications and they really need a solution and a cure. Gene therapy was approved about a year ago. It's available at Boston Children's Hospital, and we've had many patients go down to Boston Children's to talk to the team in consult. Again, this does have risks, and it isn't for everyone, and it really is reserved for patients that do have more complication. It's different but similar to transplant where the patient does get high dose chemotherapy beforehand. It's just tolerated a bit better because it's the patient's own cells that have been genetically modified that are given back to the patient. So there's less rejection. All right, next. So just some take home points for managing sickle cell disease at school. Fever, we talked about fever quite a bit, emergency, the hydration and bathroom breaks, the temperatures, outdoor temperatures, as well as, when you have that AC running in classrooms, patients might be cold or open windows, just being aware of the temperature. Expecting absences and working with students for catch up. Physical activity is great, but allowing rest as needed. And I know that you all really know these patients and children really well, and knowing their baseline and just reporting changes. We are always happy to do a school letter if needed. That gives you a little bit of detail about the patient's history and then our recommendations in general, a lot of just what I've talked about. So if you call the office and want a school letter, I would say it's probably, usually I can do them in like a few days, but I would say allow about a week. And I had mentioned that, any of our nurses can talk to you if there's an immediate issue. But generally, if it's a question that can wait a day or two, it'll get sent to me and then I'll just reach out. Keeping in touch with us in the family on pain management and if a school plan is needed. And please just know that we are here at MCCP for guidance, and we really appreciate that everything you guys do in the schools, and just really recognize that you are such a huge part of the sickle cell team. You see these kids every day and know their baseline and see when stuff is off. So I've really appreciated talking to a lot of you. I think it's really ramped up over the last year or so, our communication, and that's been really great. Next slide. Here's a few resources, some websites that could be helpful if you just are looking for some basic information to answer some questions. These are two groups that we're a part of. Synergy is out of John Hopkins, but we collaborate with them, so they're really great. And then the New England group is really helpful as well. And certainly, my email's up here. So if you have something that's not time sensitive and you want to drop me an email, I'm happy to chat with you. And also just welcome suggestions if there's other things that you're thinking about in the schools that you need some guidance on. As I've said, like this sickle cell program has really been built, over the years here, and we're always open for suggestions and hearing what you're seeing. So, thank you so much.
Thank you. Thank you very much, Shannon. We did go just a couple of minutes over, so I don't know if you have any minute for questions or.
Yeah, I'm fine. Yeah, if anyone has questions, or people can definitely reach out to me if they need to get off. I'm just gonna plug my.
Yeah, I'll share her contact information if you have any questions, but I can start with, there's one question that's blaring in my head. I don't know enough about sickle cell, and you may have covered this, or maybe I should know this, but in case not. So when somebody's in a sickle cell crisis, I understand that there's this clogging because they're not shaped correctly and they're a little sticky.
Mm-hmm.
And we're treating pain. So how are we treating the actual crisis? Like stopping, I mean, I understand, I can assume that that's why we're at risk for stroke and what have you, but how are we treating the actual crisis?
Yeah. Hydration. So if a patient was admitted to the hospital, they would definitely be on IV fluids to kind of move those things along. And hydroxyurea too. So, it's not so much in the crisis, but it's more like preventative is hydroxyurea. And then also on occasion, patients do also need a blood transfusion. And the blood transfusion is adding in more normal hemoglobin, so things kind of start getting flowing again.
And I heard
just time too,
Say it again.
Sometimes it's just time too, just treating the pain and the symptoms and waiting for things to sort of pass.
So I wonder, when you have sickle cells, I know if you're taking hydroxyurea, you may have lower platelets, so you may have less clotting, but in general, if you're not treated with that medication and you're clogging, do you have the same clotting factors? So will they clot when everything's just sitting there? Like, is there a higher risk for clot at that time in the vessels, I wonder?
Yeah, that's a good question. So as far as with hydroxyurea, the platelets are lower, but not like we kind of look for that sweet spot, so they're not like at bleeding risk. We like to keep them above 100. And then as far as clotting, yes, but I mean, you think about like stroke, because that's clotting. So they become at higher risk for stroke. So I would say, yeah. I don't think their clotting factors are necessarily different, but I don't know exactly how to answer that. But yes, I mean the clogs is what causes the strokes.
And Molly has a question. Can students with SCT, sickle cell, I would think is that treatment?
Sickle cell trait.
Oh, traits versus disease.
Oh, or okay.
Do they still have symptoms?
Stem cell transplant. No, they really shouldn't have. They really should not have symptoms. Yeah, they have generally. Let's see. I want to say it's 30% or less sickle, 30% or less of S. So they should not have symptoms.
Okay.
It's unusual to have symptoms.
Great. Does anybody else have any questions? You know what? I should stop recording.